Welcome to the Scientific Dose. Okay, let's dive right in and unravel the mysteries of liver biochemistry through a real-world clinical lens. The liver is this massive, incredibly complex chemical processing plant carrying out over 500 vital functions. But when things go wrong, it sends out SOS signals, literally microscopic enzymes and proteins dumped right into our bloodstream. Today, we're going to learn exactly how to decode those signals. To give us some structure, here is our roadmap. We will start with a patient mystery, learn the essential markers, master the diagnostic logic, look at the bilirubin processing steps, and ultimately solve the patient case.
Section 1. The clinical patient case. Meet our hypothetical patient, John. Let's establish our clinical mystery and see how biochemical lab data translates to a living, breathing human being. We've got John here, a 45-year-old guy presenting with right upper quadrant abdominal pain, unusually dark-colored urine, and noticeable jaundice, that telltale yellowing of the skin and eyes. We absolutely must keep these specific symptoms in mind as we decode what's failing in his system. Is his liver failing? Is his blood breaking down? Or is there a blockage somewhere? The dark urine is going to be a huge clue for us later on.
Section 2. Markers of liver injury, hepatocellular and cholestatic indicators.
Okay, this brilliantly illustrates the geographic division of our liver enzymes. Think of these markers as regional alarm bells. Look at the large red liver right in the center of the image. Tightly localized inside that central liver tissue, the hepatocytes, we have AST and ALT. AST, or aspartate aminotransferase, catalyzes the conversion of aspartate and alpha-ketoglutarate to oxaloacetate and glutamate. Right below it is ALT, or alanine aminotransferase, which transfers an amino group from L-alanine to alpha-ketoglutarate, forming L-glutamate and pyruvate. Now follow those blue arrows pointing outward to the right. Here we have our biliary system markers. There's GGT, gamma-glutamyltransferase, crucial for metabolizing glutathione, which is an important cellular antioxidant, and below that is ALP, alkaline phosphatase, highly concentrated in the liver and bones. So the big takeaway here, AST and ALT signal inner hepatocyte injury, while GGT and ALP point to the outer biliary tract. Now, let's compare ALT and AST a bit more closely. The crucial point here is that while both of these enzymes leak out during liver injury, ALT is our true liver-specific marker. It's highly specific to the cytoplasm of hepatocytes, where it converts alanine to pyruvate. AST, on the other hand, is a bit less specific. It hangs out in the liver, sure, but also in the heart, muscle, and kidneys. So an elevated AST means we have to rule out heart or muscle damage too. And here is a fascinating little detail. The ratio between the two is incredibly revealing. If you see an AST to ALT ratio greater than 2, that strongly suggests you're looking at alcoholic liver disease.
Section 3. Liver versus bone issues, decoding ALP elevations.
So, we just mentioned ALP, right? Well, because ALP is produced in quite a few distinct locations in the body, an elevated ALP level on a lab report is actually kind of ambiguous on its own. It comes from the bile duct cells of the liver, sure, but also from bone tissue, the placenta, and the intestine. You might look at a blood test, see sky-high ALP, and instantly think liver blockage, but honestly, it could just as easily be rapid bone growth, a bone disease, or even pregnancy.
Which brings us to a very real clinical dilemma. If ALP is highly elevated, how do we confidently know if it's a liver and biliary problem or just a bone problem? We can't just guess, right? We need a secondary test to tiebreak it. And what's really cool here is how GGT acts as the perfect clinical tiebreaker. Remember, GGT is involved in glutathione metabolism, but the key is that it's not found in bone. So if both ALP and GGT are elevated, boom, that confirms the issue is originating from the liver or biliary system, what we call cholestasis. But if you have elevated ALP with a totally normal GGT, that points directly toward a bone disease or an issue completely outside the liver. It's a beautifully simple way to narrow things down. Section 4. The diagnostic logic. Approaching hyperbilirubinemia.
All right, let's trace the exact origin of a patient's jaundice using this diagnostic flowchart. Jaundice, of course, means excess bilirubin in the blood. Starting right at the top, we measure elevated total bilirubin. If it's high, we split it up. Let's follow the pink pathway to the left first, elevated unconjugated bilirubin. This means the liver hasn't processed it yet. If hemolysis labs are positive, we're looking at hemolytic anemia. Red blood cells are bursting. If negative, it might be a genetic issue like Gilbert or Crigler-Najjar syndrome, or even a drug reaction to something like rifampin.
Now, moving to the purple pathway in the middle, if both unconjugated and conjugated bilirubin are high, we have a mixed hyperbilirubinemia. We check our AST and ALT alarm bells. If they're elevated, it confirms hepatocellular injury. Finally, let's follow the green pathway to the right. If only conjugated bilirubin is elevated, we check ALP. If ALP is elevated, it points to cholestasis, a blockage. An ultrasound of the right upper quadrant will tell us if it's an extrahepatic obstruction. If that's negative, it's intrahepatic cholestasis. Oh, and if conjugated bilirubin is high, but AST, ALT, and ALP are all totally normal, we might be looking at Dubin-Johnson or Rotor syndrome. We absolutely must compare these three categories thoroughly because urine and stool colors provide instant, real-world clinical clues. First up, prehepatic jaundice. The mechanism here is excess red blood cell destruction before anything even reaches the liver. So we get elevated unconjugated bilirubin. Now, because unconjugated bilirubin is lipid-soluble, it repels water, meaning it can't be excreted in urine. So urine bilirubin is absent. But stool color is dark due to increased stercobilin. Moving to hepatic jaundice in the middle. The mechanism is direct hepatocyte damage. We see a mixed elevation of both unconjugated and conjugated bilirubin. Since some water-soluble conjugated bilirubin leaks into the blood, urine bilirubin is present, while stool color remains normal or slightly pale. Finally, posthepatic jaundice. The mechanism is a physical bile duct obstruction. The liver conjugates the bilirubin perfectly fine, but it physically can't enter the gut. So, elevated conjugated bilirubin backs up into the bloodstream. This dumps heavily into the kidneys, making the urine very dark. And because zero bilirubin is reaching the gut to color the feces, the stool becomes distinctly clay-colored.
Section 5. Bilirubin processing steps, from hemoglobin to excretion.
To truly understand those lab results, we've got to look under the hood. Bilirubin metabolism is like this beautifully coordinated relay race, and this image maps out the anatomical journey perfectly. Starting up at the top left in the bloodstream, we see red blood cells breaking down into heme, which becomes unconjugated bilirubin. It then travels over to that large red liver on the right for processing. Once processed, notice how it transitions down through the green gallbladder and the bile duct. From there, it enters the peach-colored small and large intestines to eventually be excreted in feces. Simultaneously, a portion gets reabsorbed and travels down to the red kidneys at the bottom left to be excreted in the urine. It's an incredible visual transition from the bloodstream into the liver and out through the biliary and renal systems.
Let's break down exactly how the liver acts as a chemical conversion plant across 4 strict chronological steps. Step 1. When red blood cells naturally die off, they break down into heme. An enzyme converts that heme to biliverdin, which is then reduced to unconjugated bilirubin. And remember, this form is lipid-soluble. Step 2. Since blood is mostly water, this unconjugated bilirubin needs a taxi. So it binds tightly to a protein called albumin for transport in the bloodstream right to the liver. Step 3. Inside the liver's hepatocytes, a crucial enzyme called UGT1A1 attaches a sugar to the bilirubin. This conjugation process magically transforms it from lipid-soluble to water-soluble. Step 4. This new water-soluble conjugated bilirubin is actively pumped by the MRP2 transporter out of the liver into the bile ducts and down into the gut. Intestinal bacteria then convert it into urobilinogen, which is what gives urine its yellow color and stool its brown color.
Section 6. Solving the patient case, putting the logic together.
Okay, it's time to bring back our patient John and apply all this rigorous logic to his specific symptoms. We have all the puzzle pieces now. John's lab results show massively elevated ALP, high GGT, and heavily elevated conjugated or direct bilirubin. However, his ALT and AST are completely normal. So what does this tell us? Well, the crucial point here is that normal AST and ALT completely rule out hepatocellular injury. His liver cells themselves are perfectly healthy and conjugating bilirubin just fine. But the high ALP, GGT, and conjugated bilirubin point exclusively to a posthepatic obstruction. The flow is completely blocked. Based on our diagnostic logic, John has an extrahepatic obstruction. Look closely at this image. See that cluster of yellow gallstones trapped within the green gallbladder and firmly wedged right into the common bile duct? Because of this physical blockade, nothing can get past. The conjugated bilirubin and bile back up, stretching the ducts, which is exactly what's causing John's intense right upper quadrant pain. This backward pressure forces the liver to dump all that newly conjugated bilirubin straight into his bloodstream and out through his kidneys, turning his urine that dark color we noted at the very beginning. The liver carries out more than 500 vital functions that affect all body systems, perfectly balanced, yet decoded with just a few drops of blood. We'll conclude our deep dive today by just marveling at that fact. A clinical understanding of just a few enzymes lets us diagnose complex internal pathologies without ever making a single incision. We took a patient with pain and yellowing skin, looked at a few chemical markers, navigated a logical flowchart, and pinpointed a tiny stone blocking a microscopic duct. It's absolutely wild. So the next time you see a standard blood panel, ask yourself, what secret story are these enzymes trying to tell you? Thanks for joining me on this deep dive into liver function. Keep that scientific curiosity alive, and I will see you next time.